Good evening, everybody. Hybrid conference, a hybrid name. My name is projected as Dr. Nitin Burkale. So this is like hybrid presentation in the name of Dr. Burkale by Dr. Rakesh Gupta. Shall I move on further? Are you able to hear me?
Yes, sir.
Thank you.
You're audible.
What I like to say, I've coined this word of a clinical echocardiography. Whatever Dr. Vijay Raghavan, Professor Vijay Raghavan sir has presented, along with Satish Govind and subsequently by Dr. Parashar, this is all is echocardiography getting amalgamated in physician platform, so that we are talking of a unique kind of a phenomena which is known as clinical echocardiography. Let me present the same kind of a thing. A 69-year-old male presented to emergency department of the hospital with unusual behavior. She was brought by her sister and she said he has had a slurred speech and difficult walking due to weakness and lack of coordination. These all symptoms have progressed over a period of few weeks, and she also told of complaint of nausea and vomiting since last 3 days. That was his presentation to emergency department as she was told by her sister. When we examined the patient was restless, not able to answer the questions properly. Vital signs, he was running fever, almost 101 degree Fahrenheit. 106 was a pulse rate, BP was 150/60. Respiratory rate was normal, skin was warm and dry. Cardiovascular system showed hyperdynamic precardium with grade 2 to 6 systolic ejection murmur. There was no definite neurovascular deficit. He was able to move all 4 limbs of though a little painful movements. Investigation, ECG showed an evidence of atrial fibrillation with a rapid ventricular response rate. Heart rate was about 150 to 180 beats per minute, and the rhythm, it appears like as if it's regular, almost regular. We went on to do investigations. Whatever the investigation, the first thing we always do in emergency ward today, as is oxygen saturation was reasonably normal. We subjected this patient for a cardiac enzyme. CPK, CPK was normal, tropi was normal, NT-proBNP was mildly elevated as shown by this. Since patient was unconscious, we went on to do a CT scan head, which was normal. So was the brain. MRI was normal. And then we had an EEG, which shows a non-specific diffuse slowing. Then came our real field of doing an echocardiography, which we did. And this echocardiography showed almost normal contraction of LV function. Though the heart rate was about 150 to 180 beats per minute, it was almost normal, and LV function showed almost a reasonably normally contracting LV. And there was some amount of mitral regurgitation, which we can classify somewhere as moderate category of mitral regurgitations. But when we looked at the Doppler flow pattern, we were not able to differentiate between E and A wave. Sometimes it looked like this is an A wave, and sometimes a gross E wave was present. Though this RR difference was variable, or every systolic beat, every mitral E beat variations was variable, suggestive of atrial fibrillations. We went on to do a mitral Doppler spectral flow and E wave, E prime at the septal annulus. Then we did a lateral IVRT when we were evaluating a diastolic flow pattern of atrial fibrillation. And then color flow propagation velocity across this particular flow pattern, it comes out to be almost 30 centimeters per second, and a significant amount of mitral regurgitation, tricuspid regurgitation with a PR gradient of almost 36 millimeters of mercury. That's what we evaluated. And now the diagnosis which we came across was atrial fibrillation with evidence of raised LV EDP as well as RV pressures were definitely elevated in this patient. We went on to do a 3-dimensional echo. That was not a great picture as shown in this particular slides. We were not able to get any answer for early appendage thrombus or. Now, the course in the hospital, patient, his mental status continued to deteriorate over a period of next 2 days. He was started on broad spectrum antibiotics. His temperature continued to spike daily up to 101 degree Fahrenheit. He started having dyspnea. His ventricular heart rate was controlled. It was rapid and irregular. It was controlled with 6 milligram of adenosine 2 times, which slowed down his ventricular rate. Diltiazem and digoxin further slowed down to ventricular rate to almost 80 to 100 beats per minute with addition of beta blockers, and approximately 4 hours down the line, he reverted to a normal sinus rhythm. Now the problems start. ECG showed a normal sinus rhythm with a heart rate of almost 100 with non-specific anterolateral T wave inversion. But the issue which kept on hindering or kept on making a problematic issue was the conscious level remained the same. He was only now responding to a deep painful stimuli. 24 hours of initial hospitalization, initial management of atrial fibrillation, his heart rate again went up to almost 180 beats per minute. Something as if it was there in the beginning itself. Now the big question remains, what is the diagnosis? How to manage this case? We went on to do a neurological review. Neurological, they suggest lumbar puncture, but neck was flaccid. And though MRI did not show any evidence of involvement, encephalopathy was one possible answer for which the neurologist was very emphatic with. Another option he gave us is a viral encephalopathy with administration of steroid antibiotics. That's what his conclusion of a multi-departmental involvement. Our question was, what is the diagnosis? Why this patient is having an atrial fibrillation and how to manage this? Well, everything went on. The patient kept on deteriorating. He was on a beta blocker, getting another dose of adenosine to control his heart rate. Temperature went to 101 degrees Fahrenheit. Now the big surprise came on third day. What was that big surprise? And that what exactly happened. I was reading in the night, roughly 2 o'clock in the midnight. What could be the possible causes for this kind of a presentation? And to our surprise, look what we looked at is, we looked at thyroid. And when we looked at the thyroid, I called up the sister in the midnight, please send a T3, T4 message. And she was very emphatic saying that, shall I send it right now at 2 o'clock? I said, yes, we should send it at 2 o'clock in the midnight. And then came in the next morning, the free T4 level of almost 6 nanograms per deciliter, when the normal range is only 0.8 to 0.18 nanogram per deciliter. TSH was significantly low. And now we were able to make a correct diagnosis of thyrotoxic crisis, that's a thyroid storm, with atrial fibrillation with rapid ventricular response. And that is one possible reason why we were able to see a tall E and a very small, tiny A sometimes when we were doing a Doppler echo. Whatever we had in our pharmacy at that time of PTU and methimazole, we just pushed in through the rice tube at that time. Then another treatment options was given was Indrol, 1 milligram followed by 80 milligrams every 4 hours to maintain its heart rate of 80 beats per minute. Dexamethasone was a drug of choice, which deliberately I did not give over a period of time so as to see that patient was not having any viral encephalopathy. We did give IV fluids and along with other things and antibiotics to cover infection. Now, the 2 days time, patient started becoming temperature became normal, heart rate settled down, and finally NS was achieved without any further medication intravenously. To line up a few words about thyrotoxic crisis, thyroid or thyrotoxic crisis is life-threatening complication of hypothyroidism. Common signs symptoms of thyroid storm include hyperthermia, that's what tachycardia, that's what our patient had, hypertension, gastrointestinal, that our patient has, and a neurological illness. The most important issue was to recognize it early and start aggressive treatment to reduce mortality. Believe my words, if I were really concerned only with, or I would have confided with my neurologist at that particular moment, look, this is viral encephalitis, possibly I would have lost my patient. And what the guidelines of American Thyroid Association recommend multimodality treatment approach for anti-thyroid to control block effects of excessive circulating thyroid hormone, treatment of other systemic decompensation, congestive heart failure, shock, other things along with infection. Thank you very much for patience hearing. That's early confused male with tachycardia with elevated body temperature. Ladies and gentlemen, for the timing now, please remember atrial fibrillation with a fast heart rate, thyrotoxic crisis could be one of the manifestations with which the patients are presenting and possibly labeled as viral encephalitis. Grateful and thank you very much.